Urine alkalinization was something that was discovered in early stone management. It was a means to dissolve stones. It used to be through retrograde or antegrade flow of a dissolutant. That subsequently has been changed as we understood that you could achieve this with ingestion of medications. A lot of work was done out of Chicago by Dr. Elaine Worcester and Dr. Coe, as well as other physicians. And these people found that by taking salts, namely potassium citrate, you could raise the urinary pH of stone formers and regular individuals to the point where the salt became more solvent and would dissolve in the fluid, namely urine. When you did this, you could reduce the complexity of certain stones by shrinking them. You could even make certain situations like uric acid stone formers resolve their stone disease without needing surgery. But it's also important post-operatively, after you have treated someone, if you find that they have a uric acid stone or calcium oxalate-based stone or cystine stone, that you can prevent stone disease by, again, raising that urinary pH with an alkalizing agent such as potassium citrate to render them stone-free and keep them stone-free going forward. There are preoperative parameters that predict stones that are going to be dissolvable and or prevented with urine alkalinization. When you get into uric acid stones, they have lower Hounsfield units. With this, you can then predict along with their medical history, so diabetics, metabolic syndrome. These are patients that are high risk for uric acid stones and then calcium oxalate stones. As far as cystine stones, that's something that you've discovered after the fact. You're always able to get a stone analysis at any of the labs these days. And once you have that, you can then follow up with the patient with some additional studies quite easily and determine that they would benefit from urine alkalinization. So the case I'm presenting today is an interesting case. It's involving a 38-year-old female. She did have some comorbidities, including a diabetes mellitus and metabolic syndrome, and she does have some cognitive deficiencies. She's also essentially a solitary kidney, and she has a staghorn kidney stone. You can see how large this stone is. It's essentially compromising the whole renal pelvis. The Hounsfield units on the kidney stone were in the lower range, which we felt was consistent potentially with a uric acid stone formation. This screenshot here shows her kind of body habitus where people have a little bit of extra weight, and these kinds of things challenge the metabolic system and cause scenarios like acidic urine, which is a baseline necessary for stones to form. Intraoperative findings were that she had a ureteropelvic junction obstruction. We had to use perc-tick technique. Intraoperative findings included that this looked like a uric acid stone. With that in mind, we elected to use a more flexible scope and a high-powered laser, one that minimized the trauma to the kidney, as we knew we could always alkalinize her urine for residual stone fragments. This is a post-operative image where you see the kidney stone's been removed. We have a stent in place and a nephrostomy tube so that she's maximally drained. She ultimately went home on the day after surgery and did exceedingly well with follow-up care. This right here is simply to highlight the patient's metabolic evaluation. This was a 24-hour collection. You can see this is her repeat collection, and the key features are that she has low urine volume, she has a very low pH, and then she has a high risk, this is a supersaturation of uric acid, which she had a uric acid stone. So then what happened is we gave her potassium citrate, and you can see the urine pH went from 5.4 to 7. Our goal is to be above 6. We also dropped our stone risk right here for uric acid from 1.25 to 0.14, and the goal should be less than 1. We did, however, raise the saturation rate of her uric acid, and so that can raise the risk of calcium oxalate stone disease. In these settings, if you really are dedicated, you can identify this, and these patients would benefit from allopurinol. We do also use complementary and alternative options, such as Crystal Light lemonade is a preventing agent, and low-calorie orange juice are other ones. And all these things are better than just medication because they give you the medication, the potassium citrate, the alkalinizing agent, but they also bring in fluid. And so with more fluid intake, you produce more urine. And our favorite saying is the solution to pollution is dilution. So if you can pee more often, you dilute out the stone particles and you prevent stone disease all at the same time. And these simple interventions can be monitored on a 6-month basis. It doesn't require any additional patient stays or visits to the clinic. Preventing a stone event is going to go a long way to reducing cost and morbidity and burden of stone disease on patients. And so that's where you're going to find the biggest benefit. And it's not overly complicated to start somebody on potassium citrate or another alkalinizing agent and prevent further stone events.